Hey everyone, welcome back to another Deep Dive Explainer. Today, we are tackling a massive, complex, and honestly, incredibly important topic in the medical coding world. We're going to be walking through the complex maze of National Correct Coding Initiative, or NCCI edits, unbundling, and medically unlikely edits, also known as MUEs. If you have ever had a claim denied because of an overlapping code, or maybe you've stared at a modifier just wondering if it's going to instantly trigger an audit, well, this explainer is exactly what you need. So let's just dive right in. We absolutely have to start right here because the stakes are incredibly high. Getting these codes wrong, it isn't just about a delayed payment, it's literally about the financial and legal survival of a practice. Inaccurate billing can lead to some severe civil and criminal penalties. Now, what's really crucial to grasp here is the clear distinction between fraud and abuse. Medicare fraud is when someone knowingly submits false claims to get money they just aren't entitled to. But Medicare abuse, that actually happens when codes are misused, like upcoding to a higher level of service, or unbundling codes that really should be billed together. So the big takeaway is that even a completely unintentional mistake can be classified as abuse. That makes strict compliance absolutely vital for all of us. To navigate all this, we've got to look at our foundation. Everything we're discussing today is grounded in the official CPT guidelines established by the AMA. In the CPT hierarchy, evaluation and management, or E&M codes, well, they represent the cognitive side of healthcare. This is the physician's assessment, their medical decision-making, the overall management of the patient. This is totally distinct from procedural services, like a surgery or an X-ray. Understanding this divide, the cognitive versus the procedural, is the absolute key to knowing when and how you can actually bill for both on the exact same day. Okay, here's our playbook for today's explainer. We're going to break down these complex rules step by step. We'll look at the cost of unbundling, NCCI and MUE logic, exactly when to use modifier 59 versus those highly specific X modifiers, audit red flags, and finally, how to build some rock-solid compliance guardrails. Let's move right into our first major problem area, the cost of unbundling. So unbundling is officially defined as the misuse of codes on a claim by billing separate components of a comprehensive EM or procedural service when they really should be reported under a single all-encompassing code. Think of a bundled code like a fast food combo meal, right? Unbundling is trying to charge a patient separately for the burger, the fries, and the drink when they inherently belong together in that package. And like we talked about just a minute ago, CMS strictly classifies this as Medicare abuse. It is a massive audit trigger, which is exactly why CMS created a whole system to stop it in its tracks. And that brings us to Section 2, the NCCI and correct coding, which is the CMS framework designed specifically to catch and prevent this unbundling. NCCI is essentially your ultimate gatekeeper. Its entire purpose is to promote national correct coding methodologies and control improper coding that leads to inappropriate Medicare Part B and Medicaid payments. NCCI uses what we call procedure-to-procedure, or PTP edits. These edits group codes into Column 1, which is the comprehensive code, and Column 2, which is the component code. If you bill a Column 1 and a Column 2 code together, the system flags it. Furthermore, NCCI uses indicators to tell you what to do next. Indicator 0 means you can never bypass the edit under any circumstances, no exceptions. Indicator 1 means a bypass is allowed if and only if clinical documentation proves a distinct, separately identifiable service and you use a modifier. And Indicator 9, that just means the edit was retroactively deleted, so it's not applicable anymore. Let's look at a really practical example from our sources. Say a provider bills an established patient EM visit, code 99213, and on that exact same day performs a surgical debridement, code 11042. Because minor procedures inherently include a small evaluation component already built in, NCCI logic will naturally bundle these together and deny your EM code. To actually get paid for both, the coder has to prove that a significant, separately identifiable EM service took place above and beyond that procedure. Only then can they append the appropriate modifier, like a modifier 25, to legally bypass that NCCI edit. Moving on to Section 3, while PTP edits look at incompatible code combinations, our next topic looks at quantity. Let's talk about medically unlikely edits, or MUEs. Medically unlikely edits place a really strict ceiling on the maximum units of service a provider can report for a single patient on a single date. Basically, it stops you from billing for more units than are anatomically or clinically possible under normal circumstances. Like, let's be real, you can't remove 3 appendices from one patient. MUEs use adjudication indicators, known as MAIs. MAI 1 is a claim line edit, meaning any excess units get an automated denial right on that line, but they can be rebilled across separate lines with modifiers if you have clinical justification. MAI 2 is an absolute statutory limit per day. You simply cannot bypass it, period, unless there's a formal coverage exception. And MAI 3 is a clinical benchmark edit. It denies excess units on the same day, but it is appealable if your medical records absolutely prove the necessity of those extra units. Section 4. So, how do we legally and appropriately tell the system that our services actually were distinct and deserve payment? Well, we use modifiers. Modifier 59 is the distinct procedural service modifier. It essentially taps the payer on the shoulder and says, hey, wait a second, this procedure was completely separate from the other service provided today. It might have been a different body site, maybe a totally different encounter during the same day, or a different diagnosis. But listen, I have to give you a massive warning right here. Because Modifier 59 has historically been this broad catch-all modifier, it has been wildly overused in our industry. Because of that, it is highly scrutinized by auditors. If you're using it routinely on E&M encounters without crystal clear documentation, you are painting a giant target on your practice. So, to solve this overuse of Modifier 59, CMS introduced the HCPCS X subsets. Honestly, you should view Modifier 59 as the absolute modifier of last resort. If you can use an X modifier instead, you absolutely must. Here's how they break down. XE stands for a separate encounter on the same date. XS stands for a separate structure or organ. XP means the service was performed by a separate practitioner, and XU denotes an unusual non-overlapping service. Payers strongly prefer these X modifiers because they give them exact granular clarity, which really helps you avoid those audit red flags we just talked about. Let's see how this all builds together in a real-world clinical scenario straight from our sources. Say a patient comes in and is evaluated for a skin rash on their torso. During that exact same visit, the provider removes a completely separate lesion from the patient's arm. The documentation clearly shows distinct body sites, distinct diagnoses, and completely distinct work. Because of this rock-solid documentation, the coder can safely report the E&M code 99213 for that torso rash, and the biopsy code 11102 with the 59, or even better, the excess modifier, for the arm lesion. The chart evidence perfectly justifies the distinct service. But what happens when that documentation isn't so perfect? Let's transition into Section 5, the most common audit red flags and pitfalls coders face during the claim adjudication process. Claims get kicked back for a few highly predictable reasons. A missing modifier? That's going to result in an instant NCCI bundle denial. But the single most critical failure point is when the documentation just lacks proof of a separately identifiable service. Remember this rule. You must never, ever append a modifier simply to bypass an edit, just to get paid. You only append the modifier if the chart evidence explicitly shows a distinct, non-overlapping service. Another huge trigger is splitting EM units across multiple claim lines just to try and bypass those MUE thresholds. Auditors will catch that trick immediately. You also risk instant denials if your practice is failing to verify the quarterly CMS NCCI and MUE table updates, which leaves you coding with outdated logic. And finally, routine modifier stacking or the overuse of Modifier 59 will definitely get you flagged. To fix this, coders have got to enhance clinical note specificity and pivot to those precise X modifiers whenever they possibly can. So, how do we actually protect ourselves from all this? We move to our final section, building a bulletproof defense with coding compliance guardrails. I really want to hammer home the golden rule of this entire explainer today. The ultimate defense against any NCCI or MUE audit is medical necessity. CMS defines medical necessity as services that are proper and needed for the diagnosis or treatment of a medical condition and absolutely not provided merely for the convenience of the patient or the physician. It doesn't matter if your code combination is technically allowed by NCCI rules. If the service was not medically necessary, it will not be paid and it will fail an audit. Medical necessity is the bedrock of your coding house. To make this actionable, here is your step-by-step compliance checklist. You might actually want to take a screenshot of this one. First, ensure medical necessity is documented clearly for every single EMM service. Second, completely avoid modifier stacking unless there is profound, undeniable clinical justification right there in the chart. Third, keep a crystal clear audit trail that tracks exactly why a coder chose to override a system edit or apply a specific modifier. And fourth, you have got to run regular internal quality assurance audits specifically targeting high-risk modifiers like 25, 59, and 57.
Finding your own mistakes before the payer does, that is the true secret to compliance.
As we look at emerging best practices for 2024 and 2025, technology is completely changing the game here. Forward-thinking practices are deploying AI-assisted claim editing tools, or scrubbers, that proactively flag improper code combinations and missing medical necessity before the claim ever leaves the building. We're also seeing robotic process automation, or RPA bots, automatically validating modifier and place of service pairings. Plus, analytics dashboards are now tracking modifier denial trends in real time. This allows coding teams to provide targeted education refreshers straight to the providers to stop these errors at the source. It's pretty amazing stuff.
Navigating NCCI logic, MUE thresholds, and these really complex modifiers can sometimes feel like you're walking a tightrope without a net. But by leaning on official guidelines, relying on crystal clear documentation, and always leading with medical necessity, you can confidently master these edits and protect your practice's revenue and integrity. Keep learning, keep auditing, and definitely keep your documentation sharp. So I'd love to know, tell me down in the comments, which modifier is causing the most headaches in your revenue cycle right now? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.